I think in the next month we're going to talk about subaxial cervical spine trauma. So a little bit of outline. I'll talk about briefly epidemiology, anatomy, and the biomechanics, initial evaluation and management, and then specific upper cervical spine injuries. So the epidemiology of spinal cord injuries or upper cervical spine trauma, the incidence is approximately 60 people per 100,000 per year. Majority of these injuries come from MVCs, followed by ground level falls or falls from height, and then approximately 2.4% come from blunt trauma. Upper cervical spine injuries account for the most common site of spinal cord injuries. There's approximately 18,000 spinal cord injuries a year. Majority of those are males. And there's approximately 300,000 people living, or Americans living, with spinal cord injury. These graphs and tables are from the National Spinal Cord Injury Statistical Center. And you can just see here that there's a higher cost associated with higher level spinal cord injuries. So at the C1, C4, you can see a 50-year-old at the estimated lifetime costs approximately 2.8 million, so quite significant. And then here, the bottom table just shows the life expectancy in years for post-op injury by severity of the injury, depending on the age at the injury. And you can see here, for the high cord injuries, the older the patient is, the lower the survival time. So again, spinal cord injuries to the upper cervical spine are not that common, but they do cause, they're the most common injury to cause spinal cord injuries. In children, there's kind of a bimodal age distribution. In children, 38% of the upper spinal cord injuries are caused by MVCs. And then again, it occurs in older patients because of osteoporosis and ground level falls. Majority of these injuries occur at the C1, C2 complex. And what make up a majority of those injuries are odontoid fractures in the elderly patients. Neurologic deficits are not as common, but there are increased mortality rates again with upper C-spine spinal cord injuries, with spinal cord injury associated with it. 26 to 28% mortality with a 60% survival at approximately 2 years. There's a wide spectrum of injuries occurring from whiplash to paraspinal muscle tears to facet dislocations with spinal cord injury, and then to occipital cervical dissociation or dislocation. And we'll talk about those briefly. You can just see here, this is one of the papers we'll talk about later on down the road. With a small amount of traction, you can see that there's a craniocervical dissociation there. So understanding the upper cervical spine anatomy is important. It's important to understand the soft tissue as well as the bony anatomy. There's safe zones to be aware of that avoid the major dural venous sinuses. This is important when you're placing screws for halo treatment. There is a safe zone from the external occipital protuberance, approximately 20 millimeters lateral to this area along the superior nuchal line, and then 20 millimeters inferior, or there's a safe zone for placing screws. This slide here says 3 unicortical screws on each side. There is fixation methods that it's bicortical as well. Typically, if you look at the AOS recommendations about how to place halo screws, they recommend 6 to 8 screws for children, and then anywhere from 4 to 6 screws for adults. So it's important to, again, understand the basic anatomy, foramen magnum. Obviously, the medulla oblongata is bounded by the foramen magnum, which controls our respiratory and cardiovascular systems. It's important to know the basic anatomy here. They're labeled. We get a lot of our measurements based off of these anatomical landmarks. It's important to know where the basion is, the piston, obviously the foramen, the dens, and the relationship to each other and measurements, which we'll talk about in just a moment. So C1, it's a ring shape. There's an anterior and posterior arch, and they have paired lateral masses. There's no vertebral body or no dens and no spinous process. The C2, or also called the axis, obviously has a superior projection, or the dens are also called the odontoid. The dens articulates with the anterior arch of C1. So when we talk about occipital and C1, majority of the motion, or 50% of all flexion and extension, comes from this area. This occipital cervical, or C1, can also be called at the atlanto-occipital joint, occipital cervical junction, craniocervical junction. So you'll see all those terms used interchangeably. But it's there's convex occipital condyles that articulate with the concave lateral masses of C1. C1, C2, majority of the rotation, 50% of the rotation, head rotation, comes from this area here. Let's see, let me go on to the next page. It's important to understand the intrinsic ligaments, as these provide the majority of the stability in the upper cervical spine. So from anterior to posterior, we have the anterior occipital cervical membrane. I don't know if you guys can see my pointer, but it's a continuation of the ALL. We've got the apical ligaments that we'll show on the next slide here. And then of the cruciate ligaments, the most important is the TAL, the transverse atlantal ligament here, that you can see here. And then you've got the alar ligaments, which connect the dens to the occipital condyles. The posterior occipital membrane, actually, we can just skip that part because it's not very important. This is just another depiction of the cruciate ligaments again. C3, so the subaxial spine accounts for the remaining half of the flexion, extension, rotation, and nearly all the lateral bending comes from the subaxial spine. Posterior soft tissues are crucial for stabilizing the spine as well. The ligamentum flavum, capsule, interspinous ligaments, and supraspinous ligaments. This is another depiction. It's actually from ortho. It's just showing where the range of motion comes from our spine, our cervical spine. So it's important to understand the vertebral artery anatomy, especially when fixing surgically. So the vertebral artery is typically divided into 4 segments. Starting from the bottom, you've got the V1 segment, which is preforaminal. Typically, the vertebral artery will enter at C6 in 95% of the population. And then V3, C2 to the skull base is extradural. Within this zone, or within the atlas and the axis, the paired arteries, they typically lie within the foramen transversarium. However, at this level, the artery is susceptible to injury by shearing forces, rotation, and flexion and extension. At the upper atlantal surface, the artery curves posteriorly, so it kind of makes a right angle 90-degree turn into the transverse groove in the atlas behind the superior atlantal articular facet, and then it enters the subarachnoid space by piercing the posterior occipital atlantal membrane in dura, so it becomes intradural in the V4 segment. So the vertebral artery can often take an aberrant course around or within the C1 ring. In CT studies, there was an arcuate foramen in 24% of the patients, which leads to a high-riding vertebral artery. Ponticulus postulus, I believe we talked about it on our conference yesterday, was found to be present in 5 to 38% of the population. And this is Ponticulus posticus, stands for, in Latin, a small bony bridge. And you can see that here, where my pointer is, that it often encases the vertebral artery. So this is important when talking about screw placement here. You can see here, if you're placing a higher lateral mass screw in C1, you have the potential to run into the vertebral artery when a patient has ponticulus postulus. So something to be aware of, because it is quite, it's not uncommon. When you're dissecting the C1 arch posteriorly from the bone itself, or from the C1 itself, from the midline going out laterally, there's a safe zone approximately 8 millimeters above, and then approximately 12 to 15 millimeters below, where you don't want to carry out your dissection further laterally, as you risk running into the vertebral artery. So what's your initial evaluation of upper spinal cord injuries, or really spinal cord injuries and trauma? These are actually commonly missed injuries. There's a few other missed injuries that can have more catastrophic consequences, though. A couple of things that should raise suspicion for an occult injury are high energy mechanisms, transient neurosymptoms, and then obviously be aware of the patient's medical conditions as far as ink-spondy, dish, or prior surgeries. C-spine's clearance, really, do you have a patient has midline tenderness, no level of intoxication, normal alertness, no neurological deficits, and no painful distracting injuries. They don't have a femur sticking out or a pelvic injury or whatnot to help to distract them from their cervical spine injury. If so, you can lean towards not getting x-rays or imaging. However, I think we've kind of gone away from that, especially in patients with higher energy mechanisms. There's the Canadian rules, again, similar to the foot, determine whether to image or not based off of the patient's characteristics, age, the mechanism, the injury, and then are they able to move their neck or not. So we'll skip through that since we all know this. Age guidelines, so important to classify their level of injury and their neurologic status. I will breeze over this since we're all familiar with this, but important to know the age of grade. So imaging, obviously we want to follow the ATLS protocol. Lateral spine X-ray is the minimum screening for high energy injuries. You want to look for the relationships of on X-ray on a sagittal view of the cervical spine. You want to look at the anterior vertebral line, posterior vertebral line, spinal laminal line, and posterior spinous line. And these are just baseline radiographic measures or lines to look at to initially start with your workup and see if there's any instability of your cervical spine. Full series include AP lateral and open mouth odontoid. Flexion and extension views are not adequate to assess for ligamentous injury because the patients often have been found to voluntary guard in 33% of the cases, so definitely not useful. CT has supplanted plain films at many trauma centers. You can better visualize the craniocervical and cervicothoracic junctions. And then again, it's important to evaluate the entire cervical spine because 10 to 15% of these patients have non-contiguous spinal column injuries. MRI is less common for screening. It has a high false positive rate, and it's obviously difficult to obtain rapidly, especially in a trauma or intubated patient. But it is useful for preoperative planning and to visualize the soft tissue and ligamentous structures. So here you can just see this is the odontoid view. We'll talk about that in a second. You can also this can be looked at on X-ray, MRI, CT scan, but you can see the soft tissue shadows. These should be less than 10 millimeters at C1, 5 millimeters at C3, and less than 15 to 20 millimeters at C6. So although this measure may be non-specific for cervical injury, prevertebral soft tissue swelling may be the only evidence of severe ligamentous injury at the upper cervical spine. So it's important to be aware of these measurements, as some of these injuries again are difficult to discern on our imaging. So again, craniocervical dislocations are colloquially known as internal decapitation. They're often fatal. The incidence is estimated to be between 5 to 8% of fatal traffic injuries, and these injuries account for approximately 19 to 35% of all deaths from cervical spine trauma. We've made significant advancements in pre-hospital care and mobilization to improve survival rates, but again, it's only approximately 30% of patients who survive craniocervical dislocation. It's important to be aware that a standard C-collar can actually worsen the distraction injury. So sometimes we'll see, actually I haven't seen, but we'll see taping of the head. They'll put a piece of tape over the head or over the forehead and tape sandbags to the backboard to help pretty much keep the head on the spine, and that's preferred. So again, these injuries are challenging to diagnose, but some red flags are lower cranial nerve deficits. We all know that lower cranial nerves exit around the foramen and occipital condyles, Horner syndrome, cerebellar ataxia, Wallenberg syndrome, and dysphagia. So for radiologic assessment, again, these are important measurements. The Harris rule of 12, we've talked about this before. You want to look at the Bayesian Dens interval, or BDI, and then the Bayesian axis interval, which here are starred. Each should be less than 12 millimeters. You also should look at the Powers ratio, which we calculate frequently, and that's the distance from the Bayesian to the posterior arch divided by the anterior arch to the Opisthion, and this should be less than 1. So the classification of craniocervical dislocations, there's 2 classifications that we are familiar with, the Trainellis classification, and that it's the classification is based on the direction of the occiput displacement. So 1 is anterior, 2 longitudinal, 3 posterior, and very light traction, like approximately 5 pounds, applied to type 1 and 3 injuries can help reduce the dislocation and may improve neurologic deficit. However, if you're putting any traction to the type 2 injury, which is the longitudinal injury, it can result in progression of existing neurodeficits. So important to be aware of. Vascular injuries are common with these. Patients should undergo screening with routine screening with a CT angiogram or MRA if there's concern for, well, if there's a high energy injury, they have this injury, it's important to assess the vertebral arteries. And then again, outcomes with these injuries are poor. You can see here, again, this is a little bit of traction here. You can see that there's displacement, and then they did a occiput to C2. So the other classification, Harborview, it's based on the stability, the degree of instability. So 1 is stable, no displacement on static or dynamic injury. This can be treated in the collar. 2 is reduced on static imaging, but greater than 2 millimeters displacement with traction. And then 3 is grossly displaced. And then both 2 and 3 are treated with posterior occipital fusion. So this study here, the utility and accuracy of CT in the diagnosis of occipital cervical dissociation, it's a retrospective review of 20 trauma patients, 10 with and without craniocervical dissociation. The goal was to identify the sensitivity and specificity of the common radiographic parameters that we use to determine if there is an injury. You can see here that these are the listed measurements. And they were measured by 2 spine surgeons, medical students, and neuroradiologists. The outcome of this study is that they found that the condylocervical interval, the CCI, you can see here on the right, or the sum of the CCIs, the condylar sum, greater than 5 millimeters, is more sensitive and equally as reliable as the Bayesian DEN, BDI, and BAI, Bayesian axis intervals. Those are specific, but again, they're not very sensitive to identifying an injury. So initial treatment, again, you want to immobilize the head, pretty much keep the cranium on the cervical spine. You want to place them in reverse Trendelenburg. Obviously, you want nothing that can possibly distract, put longitudinal traction on the spine or the head from the spine. You want to perform closed reduction. You can use also a halo vest to perform a reduction and get compression. You want to minimize transfers. And then definitive fixation for these is posterior occipital fusion, which is shown here on the right. And you always want to include the C1 and C2 junction. So this study here by Chapman and Bella Barbara in 2006, looked at the diagnosis and treatment of craniocervical dissociation or dislocation in 17 survivors during an 8-year period. It was a retrospective review. 2 neuro intact, 2 incomplete, 13 incomplete. And bottom line, what they found was there is a significant delay in diagnosis, an average of 2 days, which was identified with neurologic deterioration of these patients. And then they went back and looked at their imaging and found that they were able to retrospectively identify presentation on imaging in all the cases but 1. So you know the injury can be there. It may be looking at you. You just probably may not see it. So again, the utility of the Harris lines, they're specific, but they're not sensitive. So in these patients with craniocervical dissociation, they were found, 42% were found, that's not 40, sorry, 13 out of 48 patients were found to have a normal BDI, 17 normal BAI, and they had craniocervical dislocation. So not the only tool in determining if these patients have an injury. So again,
Nina, can I interrupt you for just a second?
Absolutely, please.
Go back one slide, please.
Yeah.
So they had 5. I mean, I don't know where this 48 comes from, because you said they had 13 patients who had a neurologic deterioration. Is that the previous slide?
No, this was just 13 delayed diagnosis. Yeah.
Okay, and 5 had. Well, first of all, this study only has 17, so these are 2 separate studies, right? Because this is 48.
Yeah.
So
this was another one. This is a different study.
Okay, so what I want to know, if the study said, of the 35% of people who had normal BDI, BAI, and see that, right? How many of these people had, so they would have been missed. You would have looked at that and said, that's a normal, right?
Yeah. Mm-hmm.
But subsequently, they developed something that made them think they had a craniocervical dislocation.
Exactly.
How many of those people had a neurologic deterioration, right, during their treatment before their craniocervical dislocation was recognized? Because I think that's the interesting group, right? I mean, if you have one or of the 2 measurements that are not, because this is the measurement I use most commonly, aside from the congruency of the occipital cervical joint on CT scan, right? So if you look at these people, one or both of these measurements are wrong, then you're going to say, okay, that's a possible occipital cervical. We're going to look at that more carefully, right? Mm-hmm. But of the people who had normals, you'd pass that off. You'd go, okay, that's a non-issue, right? Mm-hmm. How many and then subsequently something happens and they get diagnosed with an OCD. How many of those people actually had neurologic, of those 18 or of the 11, how many of those people subsequently had neurologic deterioration before their injury was diagnosed? Like, have you gone through this paper with a fine-tooth comb?
Yeah, I did read it, but I can't say with a fine-tooth comb. But we can talk about that. I can read it and again and get back to you about that, so we can talk about it, because it is important to understand, what the utility of these images are, and the previous study said that it took 2 days before they developed changes in their neurologic exam before identifying them. So I don't know what the time frame is.
Of the 5 people who deteriorated neurologically, how many of them had completely normal CT scans in retrospect?
Yeah.
Right. Because I think that's the real. If you're good about looking at your measurements, you won't miss many. Right? But if there are people who come in who are absolutely normal, then we have to figure out some way to make sure we don't miss those.
Yeah, and that's what they were saying. There was a talk about this on AO Trauma a while ago, saying that a lot of times these patients are missed because they're screened in the emergency department, and they never really make it to a spine specialist because the radiologist they're just read as normal and they're sent out, and so they have delayed injury.
I don't know how many of those people are actually, because most of these are high energy injuries, so. Mm-hmm. I don't think many of them are actually sent out. They may sit around the hospital for a few days, but because if they're sent out, how do you know they're missed?
Because they were saying, this is what Kleinberg was saying, is that they come back, they present to him with neurologic decline or dysfunction, and that's when they were missed. Is it when they start to? I don't know.
We've been here for 20 years. I can't remember someone coming back after being discharged with an occipital cervical dislocation who subsequently showed up because they had neurologic decline.
Right.
Like that, I don't know that I can ever remember seeing that.
It's not common, yeah. Okay, yeah, well, I'll get back to you with that one, though. Okay, so again, the diagnosis can be challenging. You just have to have a high suspicion. They talked about doing provocative traction, just a light 5 pounds of traction to see if there is dissociation with longitudinal traction, and if so, it requires fixation. Then they recommended that with traction, that the positive test is defined as fracture displacement of 2 millimeters, AO destruction of 2 millimeters or atlantoaxial destruction of greater than 3 millimeters. So for treatment of these occipital cervical dislocations, you want to reduce and fix them. Typically, you fuse from the occiput to the C2. You need to be aware of OR positioning. They often require fiber optic intubation. You want to avoid extension of the neck. And then it's best to obtain alignment while supine. Flip prone and then reassess alignment, get supine baselines. Don't tape shoulders, again, because the traction is bad. Looking at operative positioning, I think Dr. Gelb, you've talked about this before, about looking at the posterior mandible with alignment of the anterior C2 body, but I know that this may be difficult to discern because of the patient's obviously intubated and their mouth is open. This measurement is typically preferred with the mouth not wide open. Is that correct?
Yeah, I think if they put a big bite block in, you can fool yourself, right? But I think you can look at the hard palate. I know Steve has a pretty good way of looking at the hard palate in relation to the spine. What do you do, Steve?
I don't know if he's on. I think he might be in a meeting.
He showed up this morning, so yeah, I guess he had a meeting. But there are multiple. I mean, I generally eyeball the thing. I just stand back from the table and kind of look at their face and make sure they got a reasonable head position. But you can look at the heart instead of looking at the mandible. You can look at the hard palate.
Okay. All right. Okay, so this study by Devon et al., traumatic atlanto-occipital dislocation. It's a comprehensive assessment of the mortality and improvement, and then outcomes over 15 years. So 5,300 adult trauma patients, 31%, so not a ton, met radiographic criteria for CCD, and 22 patients diagnosed on initial CT. 21 underwent occipital cervical fusion, and 1 treated with halo vest. 9 were diagnosed late or not at all, and then 23 patients survived greater than 90 days. So all 8 that died within 9 days were not treated surgically and were diagnosed only as a result of the study retrospectively. They found a higher mortality rate, let me go forward, with a lower presentation of GCS scores, so obviously higher mechanism, higher injury severity score, spinal cord injury, led to higher mortality rates, and then found that the misdiagnoses were associated with higher injury severity scores and then a better ASIER score, patients who probably had distracting injuries and less focus was placed on their spine. Okay, so we'll kind of transition over to occipital condyle fractures. These are classified by the Anderson and Mondesano classification. Type 1 and type 2 are stable, treated in a cervical collar. So type 1 fractures are impaction fractures from axial loading. They tend to be comminuted, but the tectorial membrane and alar ligaments are intact. Unilateral is typically stable, bilateral may be unstable. Type 2 is a basio-occipital fracture that involves one or both of the condyles, and the most common mechanism of injury for this is a direct blow to the skull. Again, the tectorial and alar ligaments are intact, and this is usually considered to be stable. And then type 3 is an avulsion fracture near the alar ligament insertion that results in the medial displacement of the condylar fracture fragment from the inframedial aspect of the occipital condyle into the foramen magnum. So this injury, the mechanism is a forced rotation of the head combined with lateral bending. These are potentially unstable fractures. So again, 1 and 2 can be treated with a rigid cervical orthosis, and 3 can be treated initially with orthosis or a halo vest. However, posterior occipital occipital cervical fusion may be necessary for patients who present with chronic pain or neurologic deficits or instability. And again, these fusions need to go to at least C2. Let's see. Patients, okay, so 1 and 2 treated with a collar. It's type 3 occipital cervical fusion. And then we'll, change pages to atlas fractures and transverse ligament injuries. So these are most often caused by axial loading. They usually occur, C1 is obviously a ring, but most likely often breaks in at least 2 places. The fractures usually occur in the anterior and posterior arches, which are the weakest points on the C1 ring. They have a high association with other injuries, so you have to be aware of a high association. 50% of these patients will have a head injury or other cervical spine fractures like a Dens or Hangman's fracture, teardrop, cervical burst fracture. So it's important to look at the cervical spine and head closely with these types of injuries. Patients will often complain of severe suboccipital discomfort and instability. Neurologic injury is uncommon in these cases, in these cases of isolated fractures. But when it occurs, it's the greater occipital nerve that is most frequently injured, and then followed by the lower cranial nerves. So Landau's classification for these fractures: type 1, you can see here, isolated anterior posterior arch. 2 is a Jefferson burst fracture, which was coined a long time ago. And then type 3, unilateral lateral mass fracture. You can see here that's a Jefferson fracture there. So also something to be aware of is, treatment for these has historically been based on the stability of the TAL or the TA ligament. There's a classification scheme, the Dickman's classification scheme, when we look at the type of tear. Is it intrasubstance or where it occurs, or is it a avulsion, bony avulsion, the bottom right or D of the ligament? And this has been, intrasubstance tears versus avulsion fractures have different healing capabilities. So what do we assess on imaging? So obviously we want to get the odontoid view. You can look here, the rule of Spencer, it's the sum of the lateral mass overhang. Yeah, you can see it here. Greater than 7 suggests a rupture of the TAL ligament. You can also look at the sagittal and look at the Lano-Dens interval. Normal in adults is less than 3, and normal in children is less than 5. Here again is just a pictorial of the lateral mass overhang here, and you can see this on an open mouth view. Again, you want to measure these. So this has historically been based on a study in the 70s that determines, is the TL intact? It's a cadaveric study, and they just looked at 10 specimens and determined that there is a high probability of ligament rupture if greater than 6.9 displaced, if the sum is greater than 6.9 displaced. So there's another study, let me see if this is it, here, that looked at magnification and how it impacted the measurements of the lateral mass overhang. So this was a study from Heller et al. In '93, and they looked at 18% magnification looking at C1 on an open mouth view, and found that with magnification that the transverse ligament rupture should not be inferred with a smaller overhang measure. They recommended 8.1 millimeters, or sum of 8.1 millimeters. So I don't know what Dr. Yal, do you typically use 6.9, or are you just looking more conservative?
I mean, the difference is that on CT scan there's no magnification error, right? So if you're looking at a CT scan for initial injury, I think you can use 7 millimeters. If you're looking at upright X-rays as you're following people up, I actually think the ADI is much more. I mean, I see one ring injuries where we have spread of the lateral masses, or even if it's unilateral or bilateral. The two issues are C1, C2 instability, and I think the ADI is probably the best measurement. Although if you look on the lateral film, sometimes you can't see the ADI very well because the film's slightly oblique or whatever. Right. But if you look at the posterior laminar line or the spinous process line, if you go back, right, I think that right there.
Yeah.
If you look at the spinous process line, you'll see that the C1 arch has migrated. In that X-ray, I would say that's normal. On that image, on that drawing, you can see how the C1 arch is subluxated forward. So I think that's the first place I look. I look actually at the back and try to see whether there's any subluxation of C1 on C2. Because you can have some of these injuries where there's more than 7 millimeters of spread, or even 8 millimeters. I mean, on an X-ray, you have to wonder, if you try to measure X-rays, your ability to measure accurately in small millimeter increments is quite poor.
Right.
You know, so that even if you think you're perfect, measuring the difference between 7 and 8 or the difference between 7 and 9, you know, the error of measurement is probably much greater than that, right?
Mm-hmm.
You see on and we've seen lots of people who look like they have too much spread yet are perfectly stable.
Right.
And I look at that posterior laminar line, and then I look at the ADI and try to get a sense of whether I think there's subluxation. But if you're gonna follow those people, you got to follow them carefully. I saw a guy in the office this week who's 81, who we thought had evidence of a transverse ligament rupture. We got X-rays in house, and he was totally anatomic. He had multi-trauma. He went to a rehab. He's not been compliant with his collar, and he came back, and he's clearly subluxated now. Like he definitely had some C1, C2 instability. He's also completely asymptomatic.
Mm-hmm.
And now the subluxation is fixed, right? Like he on flexion extension films doesn't move.
Okay.
So not every, you know, we might have fixed that on some level, thinking, well, that's unstable. But
Right.
there's so much room for the cord.
Right.
At this level, I'm not sure. I'm not saying be cavalier, but it just goes to point out that even if you're going to kind of say, well, that's a stable, that's not a subluxation, you got to follow it probably more than, you know, guy didn't come back for 6 weeks, right? He probably should have been seen weekly for the first 2 or 3 weeks to make sure nothing moved.
Okay, that was my question: is how often do you follow them?
Yeah, if I'm not going to fix them, if there's any question, I mean, if there's any question about spread, but I said, it looks okay, I'm going to follow it. I would follow it, you know, for the first 2 or 3 weeks, I'd follow them, you know, weekly or every 10 days. And once you get out 3 weeks and it hasn't moved, it probably won't, right? I think it's an early fail, and then it's probably okay.
Okay. Okay. All right, let's go for, where am I? Oh, there we go. Okay, so yeah, so conservative treatment with these is in a rigid collar. Again, for the isolated anterior posterior type 1s or non-displaced lateral mass fracture, or if there's not significant lateral mass overhang. If you do decide to treat these, you need to confirm, again, stability with FlexX films. And then again, you need to perform a C1, C2 fusion if the Atlanta accident interval is greater than 5. So going on to, I guess, different variants. This study here by Bransford, unilateral C1 lateral mass sagittal split fractures. So these are something to be aware of. This has typically been determined to be an unstable Jefferson fracture variant here. They looked at a retrospective review of over 6 years and found 54 patients with these C1 sagittal split fractures. 54 patients with C1 fractures and 6 had lateral mass sagittal split fractures. And patients can go on to develop this cock-robin deformity. You can see here, this gentleman here, and this requires surgical correction via occipital cervical fusion. So you want to consider, with these lateral mass sagittal split fractures, consider fixing this injury earlier on or primarily.
Yeah. So, and again, the guys at Harborview, I love them. They're good guys, right? but they have a complete, you know, their attitude is, right. It's 6 patients in 6 years.
Right.
Right. So that's 1 a year. Right. So, you know, you could make the case just the opposite, right?
Yeah.
Treat them, whatever you think. We don't use halos. We use rigid collars. For the 1 a year that falls apart, fix it. Is that better? You know, should you fix 6 people late or 54 people, you know, 58 of whom never will need surgery?
Mm-hmm.
You know, I think it just depends on there's a lot of the cervical spine literature. If you read it, this study as well, you know, says things like, oh, people came back with 3 millimeters of subluxation.
Right.
And so we thought they were unstable and we fixed them. You know, they don't say, well, they came back with 3 millimeters of subluxation and pain or new neurologic. You know, I get it. Neurologic deficits, late pain is, you know, you can fix, but I think that people are very, very aggressive because they're afraid of things, you know, totally catastrophic things happening. But on some level, catastrophic things don't usually occur late.
Mm-hmm. So for then, do you lean towards fixing these sagittal split fractures? Is that an abnormal variant to you that you would fix, or
Well,
no?
that's
You
what I'm
would.
saying. Well, I just call them unilateral lateral mass fractures. I mean, I don't think I don't
Okay.
have it right. They're just unilateral C1 ring fractures, right?
Mm-hmm.
And I think you got to be aware that there's a potential, and you see this also in lateral C2 fractures, like which are not odontoid fractures or not Hangman's fractures, but you'll see unilateral side C2 fractures very similar. And you'll see people will develop a cock robin deformity. Their head is not on straight, and so I think that it serves to maintain awareness, right? Sometimes you'll look at, I saw, who did we see this week? There was somebody who got an upright film or it was in the office. And I said, is his head really on that crooked? I mean, you look at the open mouth and you say, like, they're not straight, right? And people, or you look at the AP film and their head is clearly not straight. And you don't know whether it's because they're leaning, because they're, drooling and comatose and demented, or whether they truly have a deformity. But I think as long as you're got a high index of suspicion, so to speak, so that you kind of get on the ones that go that direction. And again, you follow them closely initially so that you don't have they don't come back 10 weeks later with a fixed deformity. It's harder to correct than if you just fixed it early. You can salvage these things pretty readily, without having to operate on a lot of people who aren't going to have a problem. But I think if you don't look for it, you'll never find it.
Sure.
I think raising the index of awareness, so that you really carefully kind of assess patients clinically and then radiographically for this cock robin, this unilateral collapse, either the C1 arch squirts out or the C2 lateral side collapses, then you'll be aware of it and you won't miss it.
Okay. All right. Thanks. So unstable is operative. Obviously, you can do C1, CR2, arthrodesis. You can use the Harms technique. You can use these transarticular screws. Were you going to say something? Sorry.
No.
Okay.
Other than I don't know anybody who uses transarticular screw fusions they work. And these days when we have navigation, if you use navigation, they're probably actually an excellent technique.
What's the advantage over doing like the Harms technique?
Well, it's a direct it's a direct fusion of the joint, right? You're going right across the joint and you're compressing it. So, and it's low profile. And if you're not, we're so facile at putting in C1 lateral mass screws, but there was a time when that was considered, a very significant, that was a huge leap. So, these are historical, right? This is something people did in the 80s and early 90s. And if you look at the literature on these things, there's about an 8% per side vertebral artery injury. Right? So, that's a significant vert risk when you do these screws. Now, with navigation, it's probably way less, but we didn't have navigation back in the day, and so it was not an innocuous technique, and it's largely been supplanted by Magarel technique or Harms technique screws.
Okay. There's also newer literature from Dr. Bransford and Bella Barbara for these isolated C1 ring fixations. So for what they term the lateral mass or the sagittal split fracture, they use these monoaxial, actually even polyaxial screws here to fuse or to internally fixate really the C1 ring. And so this is their study. Here it's a retrospective review of 12 patients who underwent this C1 fixation. Their preoperative. So really, the purpose of the study was to determine, does a transverse ligament really matter? And so their preoperative average or overhang was 7.1, and then postoperatively with the C1 fixation, it was 2.4. They found that at 3 months follow-up, their average final VAS was 0.7, and they had no significant instability at 3 months at C1, C2. 2 had to return to the OR. But pretty much there's other studies here that kind of corroborate this. Looking at C1 internal fixation, this is a study out of China. 12 cases with Jefferson's fractures, 7 with intact TAL, 5 with an avulsion, had reduction of the Lara masses postoperatively, and then found that they had good functionality and range of motion postoperatively with just C1 fixation. So you're avoiding a posterior arthrodesis, and then found that all the fractures, the ring fractures, healed on CT scan. So this may be a way to avoid fusion by internally.
So 7 of those fractures we wouldn't have fixed because the TAL was intact.
Right.
And the 5 that had avulsions, you would expect
those to heal.
To heal. So,
right.
None had mid-substance tears.
Right.
Right. So,
yeah.
And
so that's
right.
why. So what do you think? What are your thoughts regarding this fixation method?
I mean, I think it's fine. I think that, again, I think you have to decide whether or not, it's like much of the trauma literature. Some of the things that get treated, I'd say I never would have fixed that anyway. So
right.
Not relevant. And if you go in and do this and cause a tremendous amount of scarring around the posterior aspect of C1, C2, can you get it to scar down to the point that it's stable? Versus, and the TAL never heals, but they have no instability. Great.
Yeah.
Right? I mean, how much motion do they really have? I mean, the C1, C2 articulation is primarily rotational, right?
Mm-hmm.
The occipital cervical joint is flexion extension. So, you look at go back a slide, right? And they're showing you this great flexion extension film. And that's great to show you that there's no instability between C1 and C2.
Right, but it's rotating.
But how much rotation do they have
right.
at C1, C2? And would you have gotten just the same result if you had just done a C1, C2 fusion? And not have to worry about the fact that there might be postoperative instability.
Mm-hmm.
Right. So, yeah, I mean, it looks great. And, right. I get it. It probably works. I don't know that it's, it's a retrospective, right? So there's probably selection bias.
Sure.
There is no comparative group.
Right.
So it's 12 patients.
Got it. Take it with a grain of salt.
You can see I love those guys. I think they're very smart guys. I think the science here is crappy.
Yeah. No, I got it.
So I've actually done 2 of these patients, and part of the difficulty is getting the intraoperative x-rays to make sure you get a good reduction of the C1 ring. And that's sometimes not easy to do.
Uh-huh.
I've gotten post-op CT scans on these patients. One looked really good, and one looked very rotated. They had pretty decent rotation. This is all anecdotal, though. But one of my guys who had good rotation of his neck kind of lost a little bit of fixation.
How do you get this reduction? Like, what are your...
So it's kind of an axial load, right, to the ring that's splayed out the ring. So you got to do some traction.
Okay.
And you distract across it, and that allows the lateral masses of C1 to kind of once you reproduce that and do compression.
Once you have your screws in place, then you can compress.
Yeah, sometimes we've done that. Yeah, but you got to make sure your reduction is pretty good. You can sometimes see, if you dissect well enough, you can sometimes see where the fragments are in your posterior ring, and then you can try to match up the reduction that way, as you compress across the rods.
Mm-hmm.
The rod.
I think you just have to.
So I've only done this twice.
When you compress, you don't want to compress the back and have the front splay out.
Right.
Right. You got. I mean, the screws should be. The screws need to compress in kind of a parallel translational fashion as opposed to an angulatory fashion, which is hard.
Right. Okay. All right. Well, maybe I think we need to board one of these pretty soon so I can see it.
It's the same as doing a C1, C2. I mean, if you've done C1, C2 fusions, it's the same thing.
Yeah. You just put a rod between the 2 screws.
Put the rod across the back.
Yeah.
Like, no magic.
All right. So C1 fractures. There you go. We'll move on because we only have like 8 minutes. But okay, so odontoid fractures, I'll kind of breeze through this. Most common fracture, C2, approximately 2/3. Classification is the Anderson and D'Alonzo classification. We all know this. Type 1 is the tip. Type 2, fracture through the waist. High non-union rate, again, due to vascular watershed. And then the type 3, the fracture extends into the variable part of the body. Let me see here. I'll show you some pictures there. So type 1, you can see here tip 2, right at the base, and then type 3 is more of the body fracture. So again,
Nina, technically, type 3 injuries extend into the C2 articular joint. Okay, because you can have a fracture that goes deep into the body of C2 but stays medial, and that's just considered a deep type 2.
Okay.
But technically, most people, when they look at those fractures, they look at the coronal reconstruction or the open mouth view, and they look to see that the fracture itself extends out into the facet.
Okay.
That's what makes it a type 3.
Got it. Okay. So so then you wouldn't classify this then as a type 3?
No, that is a type 3. Look where the fracture line ends up.
Got it. Okay, so here. Okay.
Of the C2 body, right?
Got it.
Right, that's clearly a type 3, but sometimes you'll see it's like a V. It just goes down in the front, right? But it doesn't go wide. That's kind of a deep type 2.
Okay, got it. Yeah, I have seen those, and that's why we're like 3-ish. I don't know, but okay, that makes sense that it has to go to the facets. Okay, so non-union risk factors for non-unions is greater than 5 millimeters displaced for type 2, a fracture gap of greater than 1 millimeter, angulation of greater 10 degrees, a smoker, and then an older patient. And then again, this is because of the vascular watershed area. Surgical treatment options are halo vest. Again, the literature shows for halo vest should be avoided in the elderly patients. There's a higher mortality rate, 42% in patients over the age of 65 years old versus 20% in the non-halo group. C1, C2's posterior spinal fusions are, as we talked about before, are an option. And then, or you can also go anteriorly and do an anterior odontoid screw with 1 versus 2 screws. And we'll talk about that in a second. Show those there. That's the anterior if you're placing an odontoid screw. You want to be aware of the obliquity of the fracture here. So you can see here, the first fracture is amenable to screw fixation versus the obliquity of the second is not. You're not going to get good compression through that fracture. So advantage of odontoid screw placement is you get, again, direct fracture healing or compression osteosynthesis. You maintain the motion at C1-2, minimal blood loss. It's more useful for a younger patient and then decrease wound issues. Disadvantages, it requires a favorable patient anatomy. So we've seen this, patients with a barrel chest, it's hard to get that angle to place the screw. If they've got congenital cervical fusion or kyphosis, thoracic kyphosis or stenosis, it's hard to get this a screw placed because you can't move the neck as much. Dysphagia, there's a higher incidence of dysphagia in the elderly patients too, so this is something you should be aware of. But you also need to counter that with posterior fixation and complications with wound healing. So some pearls for odontoid screw placement, use biplanar fluoro. You may need to do a partial C2-3 discectomy to get the angle of that screw. Oftentimes the screw goes right through through the anterior portion of C2-3 disc. And then looking at evidence for a second screw placement, there's been found to be no biomechanical difference and no difference clinically with 1 versus 2 screws. I'll show that here. So looking at screw fixation for acute fractures and the remote odontoid fracture fixation, you can see here just highlighted in red that patients who are treated 18 minutes out have a decreased fusion rate 25% versus 88% were treated within 6 months, irrespective of screws. That's all the importance of that. So, oops, sorry. Treatment goals in the elderly. So you want to maintain their stability. You want to decompress neural elements, ensure no fracture compression. You want to stabilize the fracture, ensure no future compression, and then reduce their pain. And then, is fracture healing necessary in the elderly population? So there have been articles by Molinari and Vaccaro that have shown that elderly patients treated in a cervical collar, not a halo, but just a cervical collar, go on to develop a stable non-union or fibrous union. And this has been shown to be not clinically significant, so they do the same as patients who go on to fuse or who are treated operatively. So little functional difference between the populations. This study here by AO Spine, it's a multi-center perspective study looking again geriatric fractures with odontoid fractures, 100 treated surgically, 60 non-operatively, and then found treatment failure was death. Did you say something, Dr. Yo?
No.
Oh, sorry. Treatment failure was death or increase in scores or major treatment-related complications, and they found that odds ratios were increased with elderly, non-surgical management males, and then baseline neurologic comorbidity. So this study considered earlier surgical intervention in this population. However, 18% of patients, or almost 20% of these patients, died before the 12-month follow-up. So they did a subgroup analysis here, looked at the 58 patients treated non-operatively and excluded the deaths, and found that 15 patients developed a non-union and 11 required surgery. The bottom line is that they found there was no difference in outcome measures based on the union status. So again, even if they developed a fibrous non-union or stable non-union, this was not clinically different between those who went on to fuse. There's studies that look at the cost effectiveness of operative versus non-operative treatment of type 2 in elderly patients. So the annual cost of treating all these types of geriatric dense fractures in 2010, that's a while ago, was $1.5 billion. And they found that operative treatment is cost effective in patients younger than 84 years old when using 100,000 as a quality benchmark. So bottom line, surgery is more costly and less effective than non-operative treatment for patients over the age of 84. Okay, so last topic, I think we have like 1 minute, hangman's fracture, living in Edwards classification, type 1, less than 3 millimeters displaced, typically stable and treated with a collar 8 to 12 weeks, and then 2A and type 3 are unstable, more displacement, more angulation. 2A is greater angulation. Type 3 has a facet dislocation. Bottom line is for these, neurocompromise is uncommon. Whether you treat them in a halo vest, a collar if it's less than 6 millimeters, or you treat them surgically, these all have a tendency to heal. There's a 95% fusion rate irrespective of how you treat these, if you treat them one of these ways. Just pictures of treatment here. Sorry, I'm running out of time. You can also do an ACDF here. Patients with unstable hangman's fracture treated with ACDF found to have good function and good outcomes. And then there's atypical hangman fractures. These are just pictures of them. You guys can look at this slide later on. But pretty much atypical patterns of hangman's fractures can be treated in a similar fashion to the typical fracture patterns. And I think that is it. Yep.
The importance, I mean, hangman's, I have such a laissez-faire attitude towards hangman's fractures. It's unbelievable, except for type 3s. Because you can't reduce the facet dislocation because there's nothing to pull on because it's disconnected.
Right.
But really, you know, I treat almost every hangman's fracture in a collar, and the natural history is most of them go on to spontaneous fusion at C2-3 in the anterior space because the disc has been ripped. So, you know, people get crazy about these things and want to put them in halos and all, and I just haven't seen the need to do that. And we've had pretty good results. It's a canal expanding injury, except I think the importance of the atypicals is that it's no longer a canal expanding injury, because if you leave a piece of the posterior body of C2 behind with the arch, then as the anterior portion drags the C1 ring forward, you're going to pinch the cord between the residual body, you know, the piece of the body that's left and the arch that drags forward. So I think that the atypical hangmans are much more dangerous neurologically than the standard hangmans. So they deserve a very careful evaluation and potentially operative treatment if there's any concern about cord compression. But the typical hangman's fracture, you know, it doesn't. The neurologic issues are generally fairly minimal.
So you would treat like a type 2 non-operatively in a collar?
Yeah, absolutely.
What about the 2A with the angulation?
Same. I mean, I think that the issue becomes one of the 2As. The reason you need to know about 2As is because you don't want to put them in traction.
Right.
Right. That, the 2s, you can put them in traction. The 1s, you can put them in traction to reduce them. But the 2As, if you put them in traction, you make them worse. So the reason that they developed the 2A classification is to make sure that people didn't put those people, because you got to remember, we used to treat a lot of these things in traction for a couple of days to a couple of weeks to quote unquote let them get sticky, right? And then put them in a halo. So they, right, so you'd maintain the reduction. I've yet to see a series of hangman's fractures that were treated non-surgically and went on to some residual amount of deformity, say a type 2 with 5 millimeters of subluxation of C23, neurologically intact, that heals, treated in a collar or becomes stable in a collar, and anybody said, well, they have worse function or more neck pain than people who were treated surgically, right? I mean, it's just there's no data. It's not that I don't think it may or may not be true. It's just that we don't know. Right? People have just kind of said, oh, it's subluxed at C1, C2, we must fix, right? There is a fracture, I must fix it. And so I think that there's an appalling lack of outcomes data, and we've treated these things based on our fear that something horrible might happen. And that's a legitimate fear, I guess, except that there's no data to suggest that there's a high rate of neurologic injuries with hangman's fractures. Right. So,
And so the type 3s, so you can just do a C2-3 fusion and do like a pedicle screw at 2 and lateral mass screws at 3. Is that enough?
Well, I mean, it's hard. I mean, it depends. Like, if you can get first of all, you got to reduce the facet dislocation, right? And then, yes, if you can put a screw across the fracture and do a direct osteosynthesis of the fracture and get screws into the C2 body, potentially that would be adequate. I think most people would probably want to get another set of screws above the fracture, because that's a. I mean, type 3 hangman's fractures are pretty high energy. It takes a lot of energy to dislocate that facet and fracture that body, right? They're actually pretty rare. So then to have screws in C1 to kind of really control the anterior fragment of the C2, is probably not a bad idea.
Okay. And is it hard to get that reduction?
Open, it's not. I mean, a posterior open reduction, you grab the spinous process C2 and you just put it back on C3. Okay. Not that hard at all.
Okay.
Right.
Okay. Well, I think we're over time. Sorry, guys. Any other questions, concerns, comments, anything like that?
No, it was a good job. It was a good job. I mean, it's a big topic to cover.
Yeah, it's interesting. It definitely is interesting. I mean, I learned a lot through just going over this stuff. So.
Yeah, no, there's a lot to it. I think that, and there's a lot of controversy, as you can see. I think more literature supports fixing odontoid fractures that are displaced in the elderly. I think there is clearly a role for non-operative management of non-displaced or minimally displaced elderly odontoids, but the ones that are and I know Dr. Ludwig likes to talk about the subluxation of the C1-2 joint. So you look at the fracture and you try to determine how displaced the odontoid is, but also getting some sense of whether the C1, C2 articulation, the facet capsules, whatever ligamentous stability you have there might be disrupted, will also help to determine whether or not things are going to go on to union.
So then you're saying that you would get an MRI then?
No, you can just look at the CAT scan and look for subluxation of the C2-3 joint. Okay. I mean, it's the C1-2 joint.
Okay.
Right. But sometimes you'll see the odontoid fracture and it looks a little angulated, but the C1-2 joints are completely reduced. Like, okay. And then sometimes you look at it and the C1 lateral mass is posteriorly displaced relative to the C2 articular facet. And I think people are more inclined to say, okay, well, there's more soft tissue disruption there.
Sure.
And the other thing is, if you treat somebody non-operatively, and that's fine because you can always fix them later. It just prolongs their quote unquote illness, right? If you go 3 months in a collar and they go into non-union, and then you fix them and they have another 6 to 12 weeks in a collar to let them fuse. Now they've had a 6-month injury instead of a 3-month injury, right? But I don't think you lose. I don't think you lose much in terms of the ultimate outcome. You know, you can. So that's not a wrong answer either. But I think that when people lose reduction early, like, so if we see one that's non-displaced and then they come back to their first office visit 2 weeks later, you get an x-ray and now it's displaced, that's been documented to be a good indication that that's going to go on to non-union. So it's again another time when you can have a sit down with people and say, look, we thought this was stable, it's not. This is one we may want to think about doing surgery on, right?
Okay.